Hola, 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 hello and welcome. Welcome to my vet journey by Dr. Melissa Judah. Don't forget to subscribe and hit the bell. Comenzamos! Hello, this is Melissa one more time. Today we're going to continue talking about anesthesia. So if you haven't seen my previous video about the anesthesia machine, please stop right here and check it out. But if you saw my previous video, now you're ready to continue with me. So I mentioned today we're going to be talking about anesthesia. We're going to be covering selecting the appropriate anesthetic drugs and a plan for an over 3-hour surgery, common protocols and drug calculation, a pre-anesthetic examination, pre-medication, induction and maintenance, monitoring the patient during anesthesia, and possible complications that you may face and how to fix them. All the information that we're going to be discussing, I got it from Plums, Vin, and also AHA. I'm going to be leaving all the links down below in the description area just for you to check them out in case you need more information. If you are an ECFVG candidate, you're very familiar with this picture. This is from the Manual of Administration 2024. Basically, it's what we have to do to pass the anesthesia section. Part 1 is choosing your protocol and calculating dosages. They are going to give you about 45 minutes. Part 2 will be everything else, meaning from doing a physical exam, assigning an ASA, pre-medicating, inducing, and maintaining during the whole anesthesia. And for that, you're going to have about 100 minutes and then until your surgery is done. For the part that requires you to assemble and explain the anesthesia machine, please check my previous video. And the part that is pre-medicating, inducing, and maintaining, I'm going to do a whole nother video with that part, giving you tips and tricks on how to accomplish all of it in the limited amount of time that they give you. Now, pre-anesthetic exam. You're going to start with a full examination like any other dog. We're going to start from the tip of the nose to the tip of the tail. Then you're going to assess the hydration status, and you're going to pay close attention to lungs and heart sounds. You want to see if there's any murmurs or any crackles or wheezes. You're going to take your TPR, CRT, and mucous membrane, just like you do in your regular physical exam. After this, you're going to request full blood work and a heartworm test. If there was any abnormalities detected in your auscultation, then you may request thoracic x-rays and EKG. In the blood work, pay special attention to the PCV and total protein. This is because you're going to be asked to write it down in the papers and note any abnormalities as well. If the PCV is high, it usually means dehydration, and if it's low, it usually means anemia. When the total protein is high, it's usually due to dehydration, and less commonly due to chronic inflammation, neoplasia, infectious disease such as FIP, or multiple myeloma. If the total protein is low, then it may be due to hemorrhage, malabsorption syndrome, liver disease, GI disease, or kidney disease. Then, once you gather all the information, you're going to assign an ASA status. The ASA status is basically a scale that the American Society of Anesthesiologists use in order to assess the physical status of the patient that's going under anesthesia. They will classify the animals into a 1 to 5 scale category based on their overall health. Class 1 is an animal with minimal risk. It's a normal, healthy animal with no underlying disease. An example of this is going to be a young and healthy patient for an elective procedure such as a spay. Class 2 is going to be slight risk with moderate disease present. It's basically an animal with a mild systemic disturbance, but is able to compensate. An example of this would be a neonate or a geriatric animal, also an obese animal, basically a healthy patient that needs a procedure. Class 3 is moderate risk with obvious disease present. It's basically a systemic disease that may complicate anesthesia. An example of this may be a low-grade heart murmur. Class 4 is a high-risk patient or a compromised patient. It's basically an animal with a pre-existing systemic disease. An example of this would be an animal in shock with high fever, uncompensated heart disease, uncompensated diabetes, or a pulmonary disease. It's basically an animal with a systemic disease that may jeopardize anesthesia. And then class 5 is an extreme risk, is basically a patient that is dying. It's a surgery performed in an animal with a life-threatening systemic disease. An example of this would be heart failure, would be an hepatic failure, terminal malignancy. Basically, a patient will likely die with or without that procedure. Then you can use an E for emergency, and this can be added to any of the classes mentioned earlier. Here you can see a picture of the American Society of Anesthesiologists physical status classification. I'm going to leave the link down below, that way you can have a bigger picture. Now we're going to be talking about medications. All the medications that we're going to be talking next, I got it from the Manual of Administration 2024. There's going to be a lot of information, but what I want you to pay close attention is going to be to the side effects of each medication, what they are, how they act, and for how long they act. Sedatives and pain medication. The first one we're going to be talking about is acepromazine. It either comes in 2 mg per ml or 10 mg per ml. It is a phenothiazine neuroleptic sedative and tranquilizer that blocks the postsynaptic dopamine receptors in the central nervous system. It requires about 30 minutes to show full effects, and those effects are going to last about 5 to 8 hours. Acepromazine does not have analgesic properties. It has some muscle relaxation properties and may cause significant hypotension. You don't want to use this medication in MDR1 mutation gene dogs because it'll take them forever to wake up. The pre-anesthetic dose is 0.02 to 0.05 milligrams per K, sub-Q, IM, or IV slow. I personally like to work with 0.03 milligrams per K. Next, we're going to talk about benzodiazepines, basically diazepam and midazolam. You can reverse both of them with flumazenil. They bind to the GABA receptor and both are anxiolytic, muscle relaxant, hypnotic, appetite stimulant, and anticonvulsant. So diazepam comes in a 5 mg per ml concentration. It's short-acting, lasting about 15 to 30 minutes, and long-term administration causes tolerance. We don't give it IM because it doesn't absorb properly. And the premedication dose that you can use is 0.1 to 0.3 milligrams per K IV. Then the next one's midazolam. It also comes in a 5 milligram per ml concentration. This one can be given IM. It has a faster onset of action as compared with diazepam, but shorter duration, only 7 to 8 minutes when given IM. The dose is basically 0.1 to 0.3 milligrams per K, and it can be given sub-Q, IV, or IM. Next, we have dexmedetomidine, which can come in a 0.5 mg per ml or a 0.1 mg per ml concentration. It's an alpha-2 adrenergic agonist, and it can be used as a pre-anesthetic, sedation, or analgesic agent. It lasts about 30 minutes. Side effects is going to be bradycardia and AV block. You do not use atropine or glycopyrrolate to reverse or fix this. Instead, you can use antecedent, but don't go crazy if you see a heart rate dropping to 60 when you use dexmedetomidine as a pre-medication. It is normal. So as long as all your other parameters like blood pressure, CRT are okay, don't do anything about it. If you see that the patient is decompensating, then you can reverse it with the antecedent. The pre-anesthetic dose for dexmedetomidine will be 5 micrograms per K, IM or IV. Now we're going to talk about opioids. All of them can be reversed with naloxone. The first one is going to be buprenorphine. It can come in a 0.3 mg per K or a 0.6 mg per K. It's a good pain medication for mild to moderate pain. Sedation happens after 15 minutes and then pain control after 30 minutes. This medication is going to need to be repeated every 6 to 8 hours. Heart rate and blood pressure may drop, and the pre-anesthetic dose is going to be 0.02 mg per K, given IV, IM, or sub-Q. Next, we have butorphanol, 2 milligrams per ml or 10 milligrams per ml. It is an opiate kappa agonist and mu antagonist. It is a mild analgesic with antitussive and antiemetic properties. It lasts about 1 hour. The pre-medication dose is between 0.1 to 0.3 milligrams per K, sub-Q, IV, or IM, but you can go up to 0.4 milligrams per K. Hydromorphone, 2 milligrams per ml or 10 milligrams per ml. It is a pure mu agonist. It's a sedative and analgesic. Analgesic effects in dogs start in about 1 to 5 minutes post IV injection and last about 4 hours. It can cause nausea and vomiting, so make sure you pre-medicate with Cerenia before giving this medication. The pre-anesthetic dose is 0.05 to 0.2 milligrams per K, IV, IM, or sub-Q. I prefer using 0.1 milligrams per K. Now morphine. Morphine comes in different concentrations, 15, 10, 25, or 30 milligrams per ml. It is a pure mu agonist. The duration is dose dependent and it can go from 1 to 6 hours. The dose is going to be 0.1 to 0.5 milligrams per k IM. You don't want to give this medication IV because it can cause a histamine-related vasodilation and hypotension. Then we have methadone. It comes in a 10 milligram per ml concentration. It's a long duration full opioid agonist. It causes less histamine release when given IV as compared to morphine. It lasts about 2 to 4 hours and is contraindicated in GDV due to vomiting. The pre-medication dose is going to be 0.2 milligrams per k IV or IM.